Even in a high PD-L1 patient, I would not treat someone without molecular results with single agent immune checkpoint inhibitors, because we know from a phase 2 trial of EGFR mutant patients that if you find after the fact they have an EGFR mutation, they're extremely unlikely to respond to that. And in that trial, when they crossed over to having a tyrosine kinase inhibitor, 2 of the 7 people who crossed over had either grade 3 hepatic toxicity, or one patient actually had a death from interstitial lung disease from the combination. So it's actually a fairly significant risk in that situation. So generally, you can give chemotherapy if you have to start and wait, but you have to get the testing done. There is one scenario that's incredibly common that comes up all the time. These are people who get stage 3 lung cancer, who get chemoradiation and then consolidation durvalumab for up to a year afterwards. In the earlier stage setting, many people don't do molecular testing. It's not even really necessarily wrong to not test someone in the stage 3 setting, because it doesn't really change how you treat them. But 6 months into durvalumab, when they progress, now you do the testing and discover that they have a mutation, and then you're stuck because there's a significant risk of putting that person on a tyrosine kinase inhibitor. So typically, again, what I often recommend is starting that patient on chemotherapy alone, giving them at least 3 months to clear it out of their system before putting them on a TKI. There's no prospective trials in this scenario, but the consequences of treating someone is you may have to stop their treatment, and now they don't have any really good therapy, or they may have a life-threatening complication of that treatment.